Welcome to the meeting. This is on Nalaxone for high schools. Like I said, each and every one of us realizes the opiate epidemic that we have going through our nation. It affects every community within the state of South Dakota. So like I said, legislature within this year, kind of objectives for the PowerPoint or the presentation is, again, to learn the signs and symptoms, learn safety precautions, and then how to initially treat someone going through an opiate epidemic or crisis event. The Department of Social Services, the Department of Health applied for federal grant money. And like I said, these entities are helping us educate the communities, law enforcement, EMS staff, and then provide Nalaxone to those agencies. So when they first respond on an opiate crisis, get on scene, they can provide quality BLS care and then administer the Nalaxone prior to EMS arriving on scene. So again, our target was first responders. These included law enforcement, anywhere from sheriff's offices to police departments, highway patrol, game fish and parks, DCI, juvenile detention center, and then the EMS providers within the state of South Dakota. Once they complete the education in the PowerPoint, they actually request a dose of Nalaxone. And that's provided through the South Dakota Nalaxone Project. Like I said, we have just kind of baseline functions for the first responders of when to administer and when not to. So again, Senate Bill 84 went through legislature last year, and it gave the schools within the state of South Dakota the option whether they want to complete the webinars as you are today and potentially get the opiate anti-agonist, which is Nalaxone or Narcan, and there. So the governing board is there, can be non-public schools or public school systems can complete the webinar, and then they'll request the Nalaxone through the program. This is all voluntarily. It's independent school specific. So it's really not required, but like I said, the other option that school systems may have is if they have resource officers, those resource officers more than likely are carrying Narcan or Nalaxone on them now. The problems that we run into with the smaller school systems is you may only have one resource officer for your entire school system. So they may be over at the elementary school, and you could potentially have an event at the high school and the resource officer not being accessible. Pros and cons, again, we're going to learn how to identify and to treat that suspected opiate overdose, be readily available at the school's discretion. Again, the cons of it, just as I explained, if you only have one resource officer in your community, they're at the other school building, having that delay response from them. The only other alternative that schools have is relying 100% on law enforcement and your EMS or ambulance services to rapidly respond to the location and, have that Nalaxone dose with them when they get on the patient's side. So before school officials can administer the opiate antagonist, like I said, you got to go through an organized training. That's what we're doing here today. You're going to learn the symptoms, signs and symptoms of somebody experiencing an opiate overdose. Protocols, pretty vague in general. Like I said, it's just a standardized paperwork that's written. And like I said, it just says, I'm identifying this as being an opiate overdose. I'm acting in good faith, and my Nalaxone dose current, it's not expired medication. Provide quality BLS care while you're administering it and waiting for help to arrive. And then, like I said, going that way, and then making sure that we have appropriate transport arrangements for that individual, that we're storing our Nalaxone. Nalaxone is actually a controlled substance, so it needs to be secured and probably not accessible to the public, but accessible to all school administrative or staff members, that it's safe. So again, Senate Bill 84 actually has the liability or immunity so that nobody can sue us. Wonderful community that we live in now, that's always a concern is, am I going to be sued if I do something? With this bill, the school system is actually protected and nobody can take legal issues against us as long as, again, we're acting in good faith, we're identifying the patient as being an opiate overdose, and administering. And I say if we treat the patient as if they were my family member or our family member, you're always going to be on a good right side. Legislature in 2016, 2017, we had to define what a drug-related overdose is. And like I said, it's pretty much any controlled substance or other substance that's used, you know, in a manner to experience a good feeling or a high. Reluctantly, the stuff that's happening is people are exceeding their limits, so they're becoming comatose, or they potentially are going into respiratory arrest and they die from this. So we had to define what this codified laws 34-20A, there's like about 25 to 30 codified laws that are in there, all reference to the South Dakota Naloxone project. So again, big purpose why we're here today is so that school officials will learn how to respond to that opiate overdose if it ever happens in their facility. We had to have learning objectives. So again, we're going to understand what opiates do and how they work. We're going to understand who is at risk factors for experiencing opiate overdose. We're going to recognize the signs and symptoms of an opiate overdose, and then how to respond to it and how to treat it. So within your brain, you have opiate receptors. These opiate receptors, again, as you take medications or substances trying to improve the maybe discomfort for pain, as these opiate receptors get occupied by the opiates themselves, these opiate receptors also kind of influence your respiratory pattern. So the more opiates that get onto these opiate receptors, eventually what happens is these people go into respiratory arrest, so their breathing pattern will initially slow down. I say each and every one of us can survive on 8 breaths per minute or more. Okay, so if I'm breathing 8 times a minute, that's normally a sufficient respiratory rate. It's when you get below that 8 and you're only breathing 4 times a mean, that's insufficiency. So again, how does this progress? Your breathing is eventually going to slow. Like I said, they slow to that 4 breaths per minute. Eventually, their breathing is going to stop. If nobody identifies that somebody's in this event, your brain begins to have brain damage because of the hypoxia event. Your brain needs oxygen and sugar to work effectively. So if one of those, oxygen is not being supplied to it, your brain is damaged. Then eventually, your heart's going to stop. And if nobody intervenes at that point, ultimately that person is a statistic and they die from the opiate substance that they were exposed to. There's numerous opiate-specific classifications that are out there. We have natural, semi-synthetic, and fully synthetic. For the most part, opiates for the most part are any type of pain medication. So if I say morphine, codeine, hydromorphine, hydrocodone, oxycodone, or fentanyl, these medications are normally pain meds. So like I said, we're here, somebody's taking a pain medication, and it's there. If you have the prescription bottle, and that prescription bottle is labeled, don't mix with alcohol, don't operate heavy machinery, that's an opiate substance, okay? So you don't need to medically know that the medical name, pharmacological name for every pain med that's out there. If on the prescription bottle it says, don't mix it with alcohol, don't operate heavy machinery, that more than likely is an opiate substance. Why do we need opiates? Okay, just to manage pain. Each and every one of us, more than likely, sometime in our livelihood has had a prescription pain med, anywhere from an infected tooth that's causing us discomfort to maybe having a surgical procedure or even a fractured bone. So like I said, morphine's kind of used those post-surgical procedures. Hydrocodone is kind of the dental one. Codeine being mild pain. Maybe you have that cough that your chest is just sore or discomfort from. The bad and ugly one that we're battling within our society is this fentanyl, and we'll kind of get in depth more about fentanyl here shortly. So we do need opiates within our healthcare system to help these patients get through that pain event, whether it's that dental pain, surgical pain, or a fractured bone. So we need that. As I said before, fentanyl is the bad and ugly one that we're battling in our society right now. Fentanyl is anywhere from 40 to 50 times more potent than pure heroin. Fentanyl can be manufactured illegally, and they're mixing it with anything and everything that's being sold on the black market. So it's being mixed with marijuana, it's being mixed with heroin, it's being mixed with the cocaine. And these people who are purchasing this from their dealers on the street, the dealer probably doesn't even aware that fentanyl is being mixed into it. It amplitudes the high effect that they experience when they use this stuff, and ultimately it gets them into trouble where their respirations diminish down and they stop breathing, their heart stops, and they end up dying from it. In 2015, in the state or nationwide, we had nearly 52,000 deaths nationwide, pretty much opiate related. So how do we treat it? Like I said, depending on the purity of the substance that they're using, whether it's a prescribed medication, you know, it's 100%. And then you got to kind of say, how much did they take? When did they take it? You know, things like that. But Nalaxone is the antidote or the treatment for it. So these people who are subject to more potent stuff, one dose of Nalaxone may not be a sufficient amount. You may need to administer 2 or 3 to make that patient improve for you. So signs and symptoms. Signs and symptoms of an opiate overdose. First of all, as we said, this affects their breathing. In EMS and stuff, we always say we kind of do an assessment. So we always start with checking the patient's mental status. So by doing that, we're going to go up, introduce ourselves. They're more than likely going to be unresponsive, so you'll do a sternal rub. If you sternal rub them and they actually moan, roll away from your hand, try to push your hand away, ultimately we would like them to wake up and talk to us. But I always say if they're that rock along interstate, you sternal rub them and they don't respond, that's a bad sign. Okay? Then we're going to look around the scene. Do we see things that are clues to us that this may be an opiate-specific event? So we're going to look for those pill bottles. We're going to look for needles, maybe even cookers. Do I see recreational drug clues that maybe are around that maybe would lead me to be believing that this is a opiate-specific event? Then we're going to look for the overdose. So now that we've determined that the patient's unresponsive, they don't respond to my sternal rub, I'm going to look at their respiratory rate. As I said before, if they're breathing 8 times a minute or more, I'm cool with that. I really just need to monitor them. If I have accessibility to supplemental oxygen, I can give it that way. More than likely we're not, but if they're only breathing 4 times a minute, this is where you need to start doing quality BLS care. So you'll get your pocket mask out or your face shield out, and you'll start giving that victim 1 breath every 5 seconds. A sufficient breath is when you see chest movement. It doesn't need to be a full expansion of the chest, but the minute I see the chest move, that's a sufficient breath. Then I'm going to look at their pupils. If their pupils are pinpoint, all opiate substance, whether it's prescribed medications or recreational substance, will cause our pupils to go pinpoint. So that one's kind of, I always say, the nail on the coffin, that this is an opiate-specific event, and, you know, get my Narcan out, do my rescue breathing, do my CPR, and dispense my Nalaxone. Then I'm going to look, anybody that has hypoxia or starvation of oxygen, first place that you're going to see that is around their lips and fingernails. They'll kind of get ashen in appearance or maybe blue in appearance, and that's just that clue that they're not getting sufficient breaths in and out. Make sure your EMS providers are notified and that they're en route, and you know, you can give them updates. How do I differentiate between somebody who's just high or over-medicated to an actual overdose event? Both patients are going to have constricted pupils or small pupils. As I said before, that over-medicated one will actually maybe respond, moan, pull away from your sternal rub. Their speech might be slurred. They might be slurring their words as if they're intoxicated. They're drowsy, but they're breathing sufficiently. They have at least 8 breaths per minute. And these patients, I just need to monitor, maybe occasionally stimulate them. Whereas somebody that's overdosed, again, they're unresponsive to my sternal rub. They're not speaking to me. Their respirations might be less than that 8. You may hear gurgling or gargling sounds. They have that blue or ashen appearance present around their lips and fingernails. Again, provide quality BLS, do your rescue breathing with the aid of a pocket mask or face shield, and while you're doing that, get your Nalaxone and administer it intranasally. Okay? Again, we talked about the opiate receptors within your brain. The opiates get adhered to them. Eventually, it's going to affect your breathing. Your breathing slows or eventually stops. Nalaxone is the reversing agent for all opiate crisis. So again, the intranasal one, which is the white box on the screen there, is a 4 milligram dose. It's an all or nothing effect. More than sufficient, more than safe to administer. The tan box that's on the screen is probably something that your EMS staff is probably going to have within the service that they'll dispense that way. Okay. So again, what is Narcan? Naloxone knocks the opiates off the opiate receptors. And our main intentions is we want to relieve that patient of that high or overdose effect and give the body the opportunity to start breathing again efficiently on its own. Naloxone will normally have a positive response within 1 to 3 minutes after it's dispensed or administered. And it only stays in the system or in your body for anywhere from 30 to 90 minutes in duration. And we'll talk about recurrent events here shortly. Narcan can neither be abused nor cause any overdose effects. There's a small percentage, it's like less than 0.3 of our population that may get a rigid or stiff chest, but you can still ventilate them appropriately. Okay. Side effects of Naloxone or Narcan, more than likely the patient's going to experience an emesis or they're going to vomit anywhere from 20 to 30 minutes after Narcan's given or Naloxone is administered. Patient may complain of discomfort. This is normally more of a muscle discomfort to them, and it's just the oxygen getting back into the bloodstream, into the tissues, muscles. Normally the patient, and that's probably about an hour and a half after you give it, will have a large bowel movement, diarrhea, and and we'd hope they'd be in a hospital setting by that time. Patient may just spontaneously start to shiver. Depending on how long the patient has been without sufficient oxygenation, that patient might be combative or disorientated. So your safety is always priority. Talk to them in a calm, collective voice. Keep a safe distance so that they can't reach out and hurt or harm you. So as Nalaxone is administered, it goes to these opiate receptors within the brain. It displaces the opiates, and now Narcan now occupies these opiate receptors. And like I said, our main goal is to try and allow that body to breathe efficiently or effectively. As I said, the most common Nalaxone that's out there on the market is the intranasal spray. It's a total of 4 milligrams per dose. It can go into either nair or nostril. And then, like I said, once you got it there, it's just pushing the plunger and the 4 milligrams of Narcan is administered. Remember the rights for the medication. Make sure you have the right patient. So what are the signs and symptoms for a right patient? Your patient's unresponsive to external rub. Their respirations are less than 8 breaths per minute. They have that cyanosis or blue grayness around their lips or fingernail beds, and then their pupils are constricted or pinpoint. Check the expiration date of your Nalaxone, that it's not expired. Even if you get your Nalaxone out and it expired yesterday, never give an expired medication. So you would have to wait till either law enforcement arrived on scene with a current non-expired dose or your ambulance service. Administer the Nalaxone as is instructed. Lay the person on their back. Remove the Nalaxone from the box. You take it out of the foil cover, and you put it in their nose, and you push the plunger. Okay. And like I said, it pretty much self-deploys itself. Keep the patient's head tilt back. Provide support to their neck. Continue on doing BLS care. Again, you should see an improvement within that first 1 to 3 minutes. If you don't see an improvement when you kind of get to that 5-minute mark, you may consider you might need to administer a second dose. So some of these Nalaxone or opiate overdoses take more than 1 dose to effectively reverse the antigen. So after you administer the Nalaxone, again, you continue with your ventilations or your rescue breaths. Give 1 breath every 5 seconds. Sufficient ventilation is when you see chest movement. It doesn't need to be a full chest rise. After 3 to 5 minutes, if the patient's still unresponsive, their breathing rate has not improved, give them that second dose. Once they improve and they start to breathe effectively on their own, we always say place the patient in the recovery position. So you'll kind of put one arm next to their head, whatever side is going to be closest to the ground, and then you'll cross them over, roll them up to that side, kind of cross their knee. This will help so that if they do have that emesis or vomiting episode prior to EMS getting there, kind of help clear their airway and maintain an open airway for them. Considerations to always have, as I said, your safety is always number 1. So fentanyl will actually absorb or enter the body through absorption. So if you get it on your skin, you need to be cautious that you get to the sink, get your hands washed with soap and water as much as possible. We should be using gloves on any patient that we take care of. Nitrile gloves, fentanyl will not penetrate through them, but if you're carrying or using latex gloves or the food server gloves, fentanyl will actually penetrate through those and potentially hurt or harm you and make you a fentanyl exposure patient. Make sure EMS is coming. Give them updates. You can tell dispatch, hey, this person's unresponsive. They're breathing 4 times a minute. I have ashen appearance around their lips and their pinpoints or pupil. I think this is an opiate overdose. so that when law enforcement or EMS get there, they're sure that they bring their Naloxone dose in with them also. If the patient doesn't have a pulse, immediately start CPR. During your CPR process, you're going to get your Naloxone out and you'll dispense it. If the patient is gasping or not breathing, once again, initiate your CPR, provide quality rescue breaths, and administer any other additional dosage of Naloxone as you feel needed. Naloxone will work within 1 to 3 minutes. My patients don't need to wake up and talk to me. All they need to do is pretty much improve their respiratory rate. So if they're only breathing 4 times a minute when I first started my resuscitation efforts, I give Narcan, Naloxone, and now they're breathing 10 times a minute. That's a save, okay? Keep in mind, Naloxone only stays in your body. Normally that's 30 to 90 minutes. Opiate substance, think of the pain medications that you've had prescribed to you. It'll say take 1 or 2 tablets every 4 to 6 hours. So opiates will stay in your system for longer than what the Narcan will work. So the concern we need to have is they could have a recurrent or relapse event. So if you do any resuscitations, you administer Narcan or Naloxone, these people need to be medically evaluated. This will normally result in being admitted to the hospital for 12 to 16 hours just to be monitored so that that Narcan or that opiate relapse or recurrent event doesn't occur. So again, continue your rescue breathing. Patient becomes responsive in 3 to 5 minutes. That's what we'd like to see. Or, hey, the breathing improves. Now they start going through withdrawal symptoms. Again, positive response. Starts breathing 3 to 5 minutes but remains unconscious. They don't need to wake up and visit with me. As long as they're breathing 8 times a minute, I'm pretty cool with it. Does not respond to the first dose within that 3 to 5 minutes, continue your rescue breaths and administer the second dose. No response after multiple dose, again, probably pretty much saying that they were exposed to a high purity or quantity of opiates, so it may take multiple dosages to get our results. The manufacturer suggested storage is 59 to 77 degrees Fahrenheit. Ultimately, they say don't let it freeze, don't let it boil, because it will break down the components. So it should be ultimately stored between that 59 degrees and 77 degrees Fahrenheit. Watch the expiration date. The shelf life for most Naloxone products is about anywhere from 12 to 18 months. Questions and answers, okay? If you give Narcan to somebody that's in an alcohol overdose, will Narcan help this person? No, that won't. Again, if you do your assessment or your patient assessment, somebody who's intoxicated, their pupils are going to dilate or be large. So while you're doing your assessment, probably wouldn't give Narcan for this patient. What if a person's on crack, cocaine, speed, or methamphetamines? These people are normally hyper. They're normally awake. They're pumped up. So again, just because they're not unconscious, you probably wouldn't give it to them. If you did, isn't going to hurt them. Okay. And then, like I said, what is the risk of that overdose being reoccurred? Again, as we just talked about, this is about, depends on how long the opiates that they were subject to or took, the purity and the quantity, and that kind of stuff. And then lastly, if I give Naloxone to somebody and it's really not an opiate overdose, is it going to hurt them? Absolutely not. There are really no harm or side effects to Naloxone. Okay. Adapt Pharmacological Company has agreed that they would give the high schools 2 doses of Naloxone once the procedures are done. School officials participate in webinar training as today. Get a medical director on board that they're aware of it, have standing orders, staff is trained effectively, and they're willing to go that way. So again, resupplying of it, if it's administered and given, just send a quick email to the Nalaxone state.sd.us. And like I said, we don't need any personal information other than say, hey, we dispensed 2 doses of Nalaxone in our school system, and XY ambulance transported to Huron, and if you need to resupply that and we have federal funding available, we'll replace your Nalaxone for you. Any other questions you might have, you can still go to that same email. And like I said, we'll get a response to you and take care of any questions you may have. Okay. Following slides are just kind of some informational stuff. The state of South Dakota specific, and can be found at the website that's listed there. State of South Dakota, we're second to last out of all 50 states within the United States. Probably beneficial that we have a scarce population. The only state that beats us is Nebraska. The blue bars being opiate specific and the green bars being any pharmacological medications. These are just overdoses that have been reported in the state of South Dakota. Even though we have our variances where we have our highs and lows, we're still in that upward trend. So back in 2006, we had 5% overdoses. In 2016, that number increased to 8.1. This is death related. Again, blue bars being opiate specific, green bars being any other pharmacological medications. Again, still in that upward trend. 2006, we had 20 confirmed opiate deaths, and in 2016, that number increased to 38. So it still is in existence in every society, every community within the state of South Dakota. Kind of gender-wise and ethnic background, even though we have a large diversity of ethnic backgrounds, kind of kept Caucasian or white and Native American. It's about an 80-20 split, 80% being Caucasian or white and 20% being Native American. Gender-wise, there's as many females as males that are overdosing, and it's nearly 50-50 across the board. Again, death rates within the state, kind of that peak is at 24 to 44 years of age. Just them high-risk takers almost in everything that we look at. Death-related, again, pretty much at 80-20, whites versus Native Americans, and then still that 50-50 for females to males. And this is opiate-specific slide versus the last one being just any pharmacological medication. Still pretty comparable. Hospitalizations, not all opiate overdoses are intentional. The vast majority of them are actually accidental. So they get hospitalized. We know healthcare is expensive. More than likely, some of these people don't have insurance, so you and I have to make up the difference. So in 2006, we had 202 people hospitalized related to a drug overdose, and that number increased to 330 in the year 2015. Hospitalizations, age-specific. Again, it's kind of frustrating to see somebody under the age of 1 being taken to the hospital and treated for a drug-related overdose, something passed on from the mother onto the baby. The slide here, or the graph here to kind of look at is that age 15 to 24 takes a significant jump. It was like 8% in the previous slides, and now it almost doubles to 16.6. My belief is kind of the kids are leaving mom and dad's house and they're going to college life, and these people are being exposed and having peer pressure by classmates to do risky activities. If you have any questions, please give us an email or a call, and we'll try to answer as we can. Thank you for your time.